Hello, everyone, and welcome to the National Blood Clot Alliance's Journal Club discussion on antithrombin therapy, current state and future outlook. I'm Dr. Anna Parks, and I'm an assistant professor in the Division of Hematology and Hematologic Malignancies at the University of Utah. And I'm also a member of the National Blood Clot Alliance Council of Emerging Researchers. And I will be the moderator for today's discussion. And I'm so pleased today to be joined by my colleague and author of the paper we'll be discussing today, Dr. George Rodgers, who is a professor of medicine in the Division of Hematology at the University of Utah. We're also joined by Dr. Valentina Restrepo, a postdoctoral associate at the Yale School of Medicine in the Hematology Division. And finally, by Mr. Jerry Tracy, whose family has been seriously impacted by venous thromboembolism and carries a specific mutation that he'll give us a little more insight into. Dr. Restrepo and the Yale Smilo Hematology Group have been conducting next-generation sequencing with Mr. Tracy's family members to evaluate the mutation in antithrombin deficiency. He is also a public health lawyer focused on delivery system cost and quality outcomes. So just as background, thank you to the National Blood Clot Alliance for hosting today's webinar. For those of you who may be new to this organization, the National Blood Clot Alliance, or NBCA, as you can see here, is the leading nonprofit organization dedicated to advancing the prevention, early diagnosis, and successful treatment of life-threatening blood clots such as deep vein thrombosis and pulmonary embolism. NBCA is a patient-led organization, and over 80% of the board of directors has been personally impacted by blood clots themselves or had a close family member affected. It's guided by a medical and scientific advisory board comprised of nationally and internationally recognized experts in thrombosis and thrombophilia, as well as a council of emerging researchers in thrombosis, of which I'm a member, partnering on several patient-centered research initiatives. So just a couple housekeeping items before we start today's discussion. So there'll be approximately 15 minutes at the end of our webinar today for questions following the presentation. So please, if you're able to, if you have questions, please put them in the Q&A feature on your toolbar to submit the questions for the panelists, and we'll get to as many questions as we can. You can also use the chat function for introductions, but please, if you're able to, please put all the questions in the Q&A for the panelists. And today's webinar will be about an hour, and the session is being recorded. Okay, and with that, I think we'll get started. So I'll hand it over to Tracy and take it away.
Thank you, Anna. And my name is Jerry Tracy, has been said several times in the last few minutes. Basically, everyone on this call is expert in medicine or genetics, except for me. What I can bring here is my family's experience with thrombosis, which starts as a grim story, which becomes an inspiring story. Thrombosis has tragically affected my family. 5 blood relatives have had blood clot disorders, 2 have survived, and 3 we've lost. In 1980, we lost my father, Jack, at age 54 due to intestinal blood clots. In 1998, I developed a standard DVT, whatever that means, at age 46, and have been treated successfully with anticoagulants for over 20 years. In 2001, my niece Sarah had a harrowing cerebral blood clot at age 27. She had started hormonal birth control recently before that. She's been successfully treated for over 20 years. In 2007, we lost my brother John at age 55 to pulmonary embolism after many years of DVT and pulmonary embolism. We lost, last but not least, we lost my nephew Danny at age 36 in 2021 to pulmonary embolism. Danny first suffered a DVT at age 23. So clearly, some genetic disorders are at work. But for the standard testing came back negative for any family member tested for the most common genetic abnormalities known to cause clots. So the causes of our family BDT problems remained unknown for many years. In summer of 2021, after my nephew's memorial service, I went on a tear, searching for medical experts who could help us find the causes of our family's thrombosis challenges. And fortunately, we were led to Dr. Alfred Lee, Chief of Hematology at Yale Smilow Cancer Center, who's a great physician and a great human being. Next slide, please. So Dr. Lee, starting the winter of 21, tested me with many things, but most importantly, whole exome sequencing, which identifies a larger range of risk factors than the standard clinical panel. The results, my personal results, came back in August 2022 and reveal that I carry a previously unknown mutation of the SERPINK1 gene that encodes the antithrombin protein. Note, so this was a variant of unknown significance. Note that I've consistently tested negatively using the for the AT activity and AT antigen test. Those always came up negative. In the winter of 22, 23, the Yale Smilow team, of which Valentina on the call is a part, organized a Tracy family research project testing all key blood relatives to determine whether our other relatives carry the same SERPINK mutation and whether the presence of the mutant gene correlates with the occurrence of thrombosis. Next slide, thank you. In September 2023, the WES results came back for the whole family, and they were fairly dramatic. The majority of blood relatives tested carry the same SERPINK1 mutation that I do. All family members who have had thrombosis were found to have the mutation. 3 family members with no history of thrombosis were also found to have the mutation. So we went to work after that, getting all the family in touch with their treating physicians on prevention and treatment plans in light of these initial findings. A real focus on the 3 family members who had the mutated gene, but no illness, to make sure that they started seeing a hematologist as soon as possible. And I'm pleased to report that Dr. Jean Connors of Dana-Farber, who I think many of you know, has already seen my nephew Matthew, so he's one of those 3, and also my daughter Megan. Also, beginning in early 2024, the Yale Research Group started phase 3 of the Family SERPINK1 Research Project to determine the significance of these findings. So at this point, the Tracy antithrombin gene variant is now undergoing cloning. I guess it's been cloned, and purification's occurring. And I won't even pretend to know how that works, but certainly the Yale Smilow group, including Valentina and Dr. Lee, are leading the charge there. Next. So just a few, I think I've got a few minutes. Yeah. Just a few comments, perspectives, I guess, from somebody who's, dived into this pool of inherited thrombosis in the last number of years. I guess I've been in the pool for a long time without paying as much attention as I should. But roughly half of the 1 million annual VTA cases are inherited. And all of these, as everybody on the call knows, these are very round numbers here. But the underlying genetic risk factors are unknown for 80% of those cases. So that is, of the 500,000 inherited cases, 80%, that's 400,000. The causes are unknown. So obviously more powerful research, including the NGS stuff that Valentina will be talking about, better testing is needed to understand risk factors for this large group of unknowns. Secondly, and this is really important, getting data of to who's had thrombosis in these families is not an easy thing to do. Patients often have vague information about their relatives' blood clot experience, especially if you go back a generation or 2 generations and starting asking them about their aunts and uncles and then their grandparents and their information also that comes down is often not very clear. In addition, primary care physicians may not thoroughly identify and very importantly, not fully document the family VTE experience. So families need better ways to learn about and share family VTA history. Last on this line, prevention and treatment should be family inclusive as well as patient centric. And obviously it should be patient centric. But as everybody on this call knows, and really I think everybody who works in chronic care of any type, the caregiver, family caregiver, that spouse, that daughter or son, that are really key to successful treatment, prevention and treatment for the patients. So we need to do a better job of helping them do that. We also need to do a better job of helping the caregivers themselves get support, because being part of a family where these events are occurring and where it's hard to tell what's going to happen next can be very stressful and very difficult. And of course, I'm just stating the obvious with that. Last slide, please. So let's take this on a much more personal level. This is a mother and daughter. That would be my daughter, Megan. She's the mom. She's combing the hair of my adorable granddaughter, Kersey. Kersey's 4 years old. I'm a grandparent, so I'm shameless about forcing and foisting other people to see family pictures, especially grandkid pictures. And but I got you all captive, so you'll have to stay with me for a second on this. The larger point is I could obsess, and sometimes do, about my daughter, Megan, who first finally learned 8 months ago that she has the trademark Tracy Serping-1 mutation gene. But I'm also heartened that she has none of the behavioral risk factors. She has had a healthy IVF pregnancy that produced little Kersey there, and she's now being seen by Dr. Connors. I also could worry about whether Kersey has inherited that Serping gene from her mother. There's, of course, a 50% chance that she has and a 50% chance that she has not. We won't know for years. But I'm heartened that Kersey is going to grow up in a world as thrombophilia research is expanding rapidly, and that treatment of AT deficiencies and other inherent thrombosis is improving so rapidly. Finally, there's hundreds of thousands, as we just discussed, of inherited thrombosis families like mine. And we all have our hopes and our worries about our children's futures, and we're doing our best to keep them healthy and happy. I am so fortunate to be working with the Yale's Myelohematology group on this research, and I'm so proud to be part of the National Blood Clot Alliance, which is an organization full of people transforming their own thrombosis suffering into practical and powerful action. And finally, thanks to all of you on the call for being our allies. Thank you. Over to you, George.
Okay. First of all, let me thank the NBCA for inviting me to present. So I've entitled my presentation, Antithrombin, New Insights for No Thrombophilia. I chose this title because antithrombin deficiency was the first inherited thrombophilia described almost 60 years ago now. In addition to reviewing antithrombin deficiency that's inherited, we also focused on new information on antithrombin and its possible role in other disorders. Next slide, please. So the topics that I will briefly review will be some background information on antithrombin and antithrombin deficiency. And I wanted to spend a minute or two looking at Dr. Eggerberg's original paper, again, almost 60 years ago, and how, given limited resources at that time, he was able to derive so much significant information about the disorder. Then we'll briefly discuss treating antithrombin deficiency, and lastly, go over some acquired antithrombin deficiency disorders that may be amenable to treatment. And I'll probably say a few extra words about COVID infection and antithrombin. Next slide. So this is the journal article, Antithrombin Therapy, Current State and Future Outlook. It was published late last year. My co-author was Dr. Mahajaran, who's a pediatric hematologist in Southern California. Next slide, please. So some background information. Antithrombin is one of the natural anticoagulants that we have in the blood, along with protein C and protein S. All of these molecules help regulate coagulation and help it stay in balance. Antithrombin is a member of the serine protease inhibitor, or SERPIN superfamily of proteins. Antithrombin's primary role is to inhibit thrombin and factor Xa and a variety of other activated clotting factors as well. It's primarily made in the liver, has a reasonably long half-life, and clinically, what's really important is that heparin and low molecular weight heparin dramatically increase the activity of antithrombin. Next slide, please. So this figure was taken from the paper. It shows the function of antithrombin in this slide. If we look at panel A, antithrombin is depicted as the blue structure. This is a computer model of the protein. The orange-pink area represents the heparin binding site of the molecule, and the black ball and stick model to the right is heparin pentasaccharide, the active species of heparin that binds antithrombin. Panel B shows the pentasaccharide bound to the binding site, and when that occurs, the active site or reactive site of antithrombin, the green part at top, is exposed. Panel C shows the interaction of antithrombin in blue, the green reactive site, and the yellow blob represents thrombin. And instead of the heparin pentasaccharide, we show unfractionated heparin binding to both thrombin and antithrombin. Next slide. So we can classify antithrombin deficiency into those states where it's inherited or acquired, and both situations of antithrombin deficiency are highly associated with thrombosis. Next slide. So a few words about inherited deficiency. Again, it was described about 60 years ago. If we look at a population of normal people as reflected in a blood bank survey, maybe 1 in 600 persons will have inherited antithrombin deficiency. If we look at a population of patients with venous thrombosis who are likely to have an inherited disorder, those who are younger, those with spontaneous clots, maybe 1 in 25 of those people will have antithrombin deficiency. The deficiency results from gene variants in SERPIN-C1, as Jerry has described. It's an autosomal dominant disorder, so both males and females will be affected. And typically, antithrombin levels are about half normal, maybe ranging between 40 and 60%. Clinically, it's associated primarily with venous thromboembolism. And as Jerry described, some of these locations of clots can be in unusual places, such as the abdominal blood vessels, especially mesenteric venous thrombosis. Another unique clinical feature of antithrombin deficiency is the association with heparin resistance. In antithrombin deficient patients, typical heparin doses that would normally prolong a laboratory clotting time that doesn't happen because heparin requires antithrombin to work. And so that leads to the phenomenon of heparin resistance. Next slide. So Valentina is going to discuss more on this, but here's an introductory slide about the types of antithrombin deficiency and some of the genetics. The type 1 patients have a quantitative deficiency of the protein. This is where both the antigenic and the functional or enzymatic assays are similarly decreased, usually about half normal. And these usually result from nonsense or null variants in the SERPIN-C1 gene. And these are thought to represent the vast majority of antithrombin deficient patients. The type 2 or qualitative deficient patients usually have missense mutation that leads to a defective protease. The amount of protein is normal, but it doesn't work normally. And this is usually associated with a lower thrombosis risk, but many type 2 cases in the population are undetected. So usually, and it looks like Jerry's family is an exception, but usually if you evaluate patients with a functional or enzymatic assay, they will be successfully detected. But we'll hear more later about this unusual case of Jerry's family. Next slide, please. So let me just say a few words about Olaf Egeberg's seminal paper, again, published about 60 years ago. He was a Norwegian physician. And if we can go to the next slide, this is the kindred that Egeberg described. There's 4 generations of family members. You can see males and females both affected. Males are the squares, females are the circles. And the patients who experience thrombosis are darkened. And more ominously, you see the circles or squares with the crosses above them. These are patients that died of thrombosis in the kindred. The 2 arrows represent a mother, age 45, and her son, age 12, who were admitted to an Oslo, Norway hospital that Dr. Egeberg initially evaluated. And later on, he went ahead and tested other family members. And basically, if we can see the next slide, we'll see a summary of his conclusions. And again, it's striking that 60 years ago, when our laboratory techniques weren't that sophisticated, that he was able to derive this much information from the family. I'm just going to start reading on the 3rd paragraph. Plasma antithrombin 3 or progressive antithrombin activity was abnormally low in members with a history of thrombosis and in some of their children with an average level of about 50% of normal. Heparin resistance, measured with plasma heparin thrombin time, was increased in members with a low antithrombin 3, and plasma heparin cofactor activity was decreased. The results strongly support the explanation that antithrombin 3 and heparin cofactor are one and the same plasma substance, and that deficiency of this antithrombin can cause a severe tendency to thrombosis. Antithrombin deficiency seems to be inherited as an autosomal dominant trait. Next slide. So how do we treat antithrombin deficiency in patients with thrombosis? Well, acutely, we anticoagulate with several options: heparin, low molecular weight heparin, or one of the newer direct oral anticoagulants. However, because of the issue of heparin resistance, if we use unfractionated heparin, we may have to replace antithrombin so heparin can actually work. And we can do that either with antithrombin concentrate or fresh frozen plasma. And then lastly, patients receive long-term anticoagulation, either with warfarin or with one of the direct oral anticoagulants. Next slide. So if we replace antithrombin, again, we have a choice of plasma or antithrombin concentrate. If we use plasma, for those who are severely deficient with levels of perhaps 50%, we need to use many units of plasma, maybe 4 to 5, to achieve a normal antithrombin level. And when we do that, we run the risk of several transfusion issues, including volume overload, transfusion-related acute lung injury, and other transfusion reactions. The other option is to use antithrombin concentrate, and the formula is shown in terms of how to determine how many units we need to give patients to achieve a 100% level. But because this is a lyophilized concentrate, there's no volume overload issues, there's no transfusion reactions. There's some minor adverse events that were described in clinical trials, but they appear to be not a big deal. And we can infuse this concentrate either daily or every other day to try and maintain a normal antithrombin level. Next slide. So this is a transition slide. It's taken from the paper. The left-hand portion shows the material that we've already covered in terms of heparin interacting with antithrombin to regulate coagulation. The right side of the figure shows some data from several years ago where antithrombin was shown to mediate anti-inflammatory effects, shown in the diagram, or effects on neutrophil endothelial cell interaction, cytokine release, etc. And so these results led to studies investigating the role of antithrombin in other pathways and other disease states. And so I'd like to go over some of those now. Next slide, please. So this table is taken from the paper. The current approved indications by the FDA for use of antithrombin therapy are treatment of inherited deficiency and treatment and prevention of perioperative or peripartum thrombosis. So all of the other uses that I'm going to mention are off-label. And if for those who are interested, the references in the paper can give more details of some of these indications. So those that have been extensively reported include using antithrombin replacement to manage heparin resistance in ECMO. ECMO stands for extracorporeal membrane oxygenation. This is a device that's used in critically ill patients who need oxygenation, and many of these patients experience heparin resistance and thrombosis. The second, treatment prevention of sinusoidal obstruction syndrome or veno-occlusive disease. This is a complication of bone marrow transplant, and many of these people require treatment of thrombosis, and it frequently is associated with low antithrombin levels. Management of venous thrombosis throughout pregnancy and the postpartum period in antithrombin deficient patient. You would think this would be an approved indication, but it isn't. I recently had an antithrombin deficient pregnant patient and used antithrombin replacement therapy throughout pregnancy, and it was successful. The fourth listed reported indication, management of heparin resistance in cardiopulmonary bypass patients. Maybe a quarter of these people become heparin resistant due to antithrombin deficiency, and antithrombin is helpful in anticoagulating this group. Anticoagulation in patients undergoing a form of dialysis called continuous renal replacement therapy. That's a very similar issue as described for ECMO. thromboprophylaxis in pediatric patients with chylothorax. So pediatric patients who undergo heart surgery, complication of that surgery is damage to the thoracic duct that can cause chylothorax, which leads to a thrombotic hypercoagulable state. And many of those patients are responsive to antithrombin replacement. Patients with acute lymphocytic leukemia who have a coagulopathy, who undergo asparaginase treatment. Asparaginase can cause a thrombotic risk and acquired antithrombin deficiency. And the ISTH, International Society of Thrombosis and Hemostasis, has a guideline that recommends antithrombin replacement for this group of patients. One of the controversial areas is treatment of sepsis and sepsis-associated DIC. I think in Japan, they have a guideline that recommends antithrombin replacement in DIC, whereas other countries, this is more controversial, and those guidelines do not recommend antithrombin replacement. Next slide. Two other categories for which there's less data are shown on this slide. The emerging category, thromboprophylaxis and management of patients with COVID-19. I found this especially provocative given that 1 million Americans died of COVID, and we really, while we have vaccines, which may be helpful in preventing the disease, we don't have great treatment. But it turned out that there's basic science data that demonstrates antithrombin can inhibit a key enzyme that's required for COVID-19 to infect cells. And there's clinical data to show that COVID-19 patients have low antithrombin levels, and that the severity of antithrombin deficiency correlates with death in these patients. What we're missing is a clinical trial in COVID patients to demonstrate survival. There was a clinical trial that was started at the end of the pandemic. Unfortunately, it did not accrue enough patients to arrive at a decision. It was terminated prematurely because of lack of accrual. But this could be another potential treatment option if we have another coronavirus pandemic in the future. The other emerging category was actually the subject of the Journal Club last year by NBCA, that is thromboprophylaxis and management of hemorrhagic shock in critically injured trauma patients. In this situation, antithrombin therapy increases the efficacy of low-molecular weight heparin prophylaxis. And then lastly, the investigational uses. These are still at the basic science level, but there is data in a type of brain cancer called glioblastoma, and in colorectal and lung cancer that antithrombin may inhibit tumor cell growth. Next slide. So, in summary, antithrombin is a key protease in regulating coagulation and other pathways as well. Inherited antithrombin deficiency is a severe thrombophilia. Heparin resistance is associated with antithrombin deficiency. Anticoagulation with or without antithrombin replacement are treatment options. And antithrombin replacement therapy outside of treating inherited deficiency is controversial. And with that, I'll turn the floor over to Valentina.
Thank you, Dr. Rodgers. So let's get a little bit ahead. Great, thank you. So we will now briefly review what we know about the genetic basis of venous thromboembolism, or VTE, and the implications this has for our field. So we know that VTE has a strong genetic basis. Its inheritance follows a multifactorial or non-Mendelian inheritance model, which basically means that multiple genetic factors contribute to the risk of developing VTE. Next, please. So studies with family-based studies have shown that the risk of VTE in individuals with unaffected sibling is 3 times higher than that of the general population. Next, and interestingly, studies in monozygotic twins have shown that 55% of VTE incidence is attributable to genetics. However, only 20% of patients who develop VTE, in only 20% of those patients, we managed to identify at least one of the major hereditary thrombophilias, which calls our attention because this suggests that most patients who have VTE may have mutations in other genes that we don't yet know much about. And this is where next generation sequencing or NGS may be able to help us identify these so-called like more obscure mutations that are not as well described. Next, please. So to make like a brief review of what has been like the history of discoveries of the involvement of genetics in VTE, I made this small timeline. So during the second half of the 20th century, what we know as the major hereditary thrombophilias were identified. So as Dr. Rodgers pointed out, in 1965 was the first time in which antithrombin deficiencies were described. Then during the 80s, protein C deficiency and protein S deficiency were described. And then later in the 90s, factor V Leiden mutation and prothrombin gene mutation were described. Then with the advent of next generation sequencing or NGS during the early 2000s, we finally got the chance to be able to obtain whole genome sequencing very quickly, which allowed us to study a much more vast array of genes related to diseases. And so in the context of VTE, in 2005 and 2008, three other genes were identified. We found alterations in fibrinogen gamma and platelet glycoprotein 6, as well as factor 11. And then since 2009 onwards, the advancements that we had already obtained with NGS applied to genome-wide association sequencing and SNP studies allowed us to further identify a much more wider array of genes that may be involved in VTE development. And with this, like since 2012 until today, several panels of genes that may be involved in VTE have been designed and developed. And even here at Yale, we developed a 55 gene panel to study bleeding, thrombosis, and platelet disorders. And the ISCH also developed a thrombogenomics panel, which in 2016 only consisted of 63 genes. And the last update in 2019 consisted of a 96 gene panel. So all of this is to say, all of this is to show that as time goes by with new genetic analysis machinery and systems, we are always able to identify new genetic variants that are allowing us to better understand the disease processes behind VTE. Okay, so overall, all of this has allowed us to increase our understanding of thrombosis and thrombophilia, and this is particularly useful for us as clinicians when treating patients. Not because right now it alters much management, because that is still a very controversial topic. It really is on, alteration in management really depend on a case-by-case basis. And it has many implications, particularly patient preference. But it is also very important to many patients to be able to know if there is some variant in their family, if their family members may have this variant as well. For example, in Mr. Tracy's family, we were able to identify that there may be a possible variant. It's called a variant of uncertain significance. So it requires of us to do further studies to determine if that variant really has a pathogenic significance or not. But the point is that finding these things gives patients a little bit more of knowledge and a little bit more of power over this disease, which would otherwise remain obscure as it was before. And that's it.
Great. Well, thank you so much, Mr. Tracy, Dr. Rodgers, and Dr. Restrepo. We have a few questions from the audience generated from your compelling talks. So it's okay. I'll start with you, Mr. Tracy. There's a few questions just in the chat, sort of more about the particulars of your family history. I think actually probably the broader question, and this can be for Mr. Tracy or Dr. Rodgers, is, in what populations is inherited antithrombin deficiency most prevalent? And maybe just a touch more about the genetic underpinnings, meaning like how it's inherited, for example, because one of the questions was about consanguinity.
So who should go first?
Go ahead, Jerry.
Yeah, go ahead.
Well, I'll go first since I'll have the least to offer, except, my sample is one family. In terms of other risk factors, and I may, not be addressing the exact point of the chat question, but the things we've seen as we've, looked at our family comprehensively. First, almost all the cases are male. Okay, I mean, and the 3 deaths that occur were also men. All of those 3 men developed some version of either heart disease or VTE very young in life. My brother was 19 years old when he had his first set of VTEs. My nephew was 20. My father had his first heart attack in his mid-30s. He was part of a generation. He was a veteran. He was, navigator on a B-24 aircraft, which means when he was 20, he was smoking 3 cigarettes a day and then getting in an airplane in very cramped quarters, so much for immobility. And, a lot of things going against him. So I don't know if that, that's really right off the top of my head. Obviously, Dr. Lee and Valentina and their group are digging into this in a much more scientifically informed level. George, over to you.
Did the question relate to ethnicity? Is that, Anna?
I think it's several fold. There's a few questions that relate to like inheritance pattern, which I think you may have mentioned, and then also I think race and ethnicity, maybe thinking about in whom we might suspect it.
Well, I'm not aware of any ethnic exclusion for antithrombin deficiency. I think it's been found in multiple races. So I don't think there's anything unique about it. I think that's true although factor V Leiden prothrombin gene mutation are primarily Caucasian genetic risk factors. Antithrombin has no such exclusion. What was the other question?
There was also a question about whether having family members who are related or for like intermarriage in a family predisposes people to inheriting this genotype. I think perhaps getting at that's autosomal dominant versus autosomal recessive.
Sure.
If you could just explain that.
Usually the consanguinity is usually most important for recessive disorders. And antithrombin deficiency appears definitely to be a dominant trait.
Yep.
Great. Thank you so much for clarifying that. There's a question from Leslie Lake in the chat, which is a great question. Kind of gets to what Jerry was discussing a little bit about family members who've tested positive for the mutation, but not yet manifested with VTE. So, Dr. Rodgers, could you just explain for women who've tested positive for any genetic form of antithrombin deficiency, but have not had a clot and are planning to get pregnant, how would they be treated? And when they become pregnant, would that treatment change?
Well, I would encourage them first to speak to a high-risk obstetrician, but at a minimum, I would probably give them prophylactic anticoagulation, starting with low molecular weight heparin, starting when they are trying to get pregnant. But I would encourage them to have a detailed discussion with high-risk OB about all of those issues.
Yeah, it's a great point. And coordination between OB and hematology, super important, or thrombosis specialist. Another question that's come up in a few different ways is sort of the testing. So Dr. Estrepo, would you be able to just talk to us a little bit? So I loved how you talked about how this is a very complicated topic, actually. There's a lot of debate about who to even send the big 5 thrombophilia tests in. There's discrepancies among the various guidelines. It doesn't always change management. So how do you decide that? And then how would you integrate this new testing in, either these new groups of genetic tests like you were describing you have available at Yale, testing for the various genes that may not be tested just with our standard big 5 measurements of activity, and then integrating these new methods of genetic testing that scan the whole genome.
Right. Hi, thank you. So basically, choosing in which patient to assess for thrombophilia, just with the big 5 or with, these bigger extended gene panels. So it really is, of course, it's a very tailored decision between the clinician and the patient, precisely because of what you say. Like, there is a lot of controversy in the field, and guidelines don't always agree with each other. So it really depends on a case by case decision type of situation. Basically here at Yale, we usually send the NGS panels. If we test for the big 5, we usually also send the NGS panel. And a good thing about doing that is that sometimes when you test for the big 5, as we said, we don't find anything. But then when you send the NGS panels, it you can find something. For example, in Mr. Tracy's case, his antithrombin activity and antigen levels were normal, as he said before. But then when the extended gene panel was done, then this variant was found. So usually it's a thing that's done hand in hand here. But when to send it or when to do it or not to do it, it's really a very tailored decision of each clinician with their patients.
Great, thank you. Mr. Tracy, I'd love to hear your perspective. You were mentioning how you think that clinicians could better support families affected by genetic or inherited thrombophilia. What's your perspective on how to help patients make decisions about when to send this testing and then what to do with that information when they get it back?
Boy, those are such tough questions in the real world. And if you put it in the context, which both Valentina and George were talking about, of all of a sudden, for years, and I'm sounding like I know what I'm talking about in terms of treatment, but which is sort of, there was the big 5 or 10 standard clinical tests that were done, and when you should use those, and the way this whole next generation sequencing opens things up with all these rare risk factors, or a new take on an existing risk factor like antithrombin deficiency, all of a sudden you're going to come up with all these additional people who are getting this tantalizing, mutant gene. And I'll tell you what I come back to, and again, we're a sample of one, as exciting and trendy, and I mean this with complete respect to Dr. Lee and Valentina and the wonderful work they're doing, how important that all is down the road. The fact that my family now has got this, a whole bunch of them have this thing, this label called SERPINK1, SERPINK1 mutation. That's, what do we do about that? Kind of what we're going to do anyway, the basic prevention, stop the clot methods, anticoagulant treatment if you need it, what the probabilities, what the meaning of these newer risk factors, like, SERPINK1 mutation, the answers to that, we as a family can't depend on those in the short term. So what we're focused on is those bread and butter, and this is what National Blood Clot Alliance does, and does so extremely well. That's the key short term. So that's a long-winded way of saying where some of these newer results come in. We just don't know yet. They're incredibly important, but we just don't know what that means for what a real family is going to do, tomorrow, and next 6 months, next year. Does that make sense?
Absolutely. That's so helpful to hear your perspective. I think the summary is that we all feel a little confused and a lot of hesitation about using this, even though we know in our hearts that it's a powerful technology. So thanks for putting a personal face to that.
I'm sorry, Anna, can I just quickly add to that?
Of course.
And this gets into families making the decisions themselves that they're comfortable with. Our family is, we want to know all the facts. And I remember when we started this 3 years ago, should be, and some of our family members are more sensitive, emotional than others, blah, 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 right? Like any family. Do we tell this one that way? Are we really careful? And just the whole family said, we want to know. So they all agreed to sign on to Dr. Lee's and to see if this thing called SERPINK1 mutation applied to them or not. Some of them could have chosen not to participate. They all wanted to participate. And the fact that some of them end up, my daughter, I got the news I got on September 1st, 23, is that my daughter, I have 3 kids. My daughter and my son have the SERPINK1 mutation. What does that mean? And my oldest son does not. The oldest son has 2 grandkids. He has 2 kids. I have 2 grandkids. They, miss they don't have the SERPINK1 mutation issue. My daughter, I just put up on the screen there, my granddaughter, she may. And but everybody in my family wanted to know everything. But that may not be what every other family wants to do. And I would not judge, what they would decide.
Great. Well, thank you so much again for sharing that perspective. We just have a couple minutes left. So there's 2 big topic areas I'd love to cover, and I'll open it up to Dr. Rodgers or Dr. Restrepo. So one is testing. So there's some questions about the reliability of testing both the quantitative antithrombin level as well as the qualitative level. How often are both sent? Which is more accurate? And then how often would you just go ahead and send the genetic testing? So that's one topic area. And then the second is treatment. basically how often and when should we be using antithrombin supplementation? So testing and treatment.
Let me just make a brief comment. The tests are actually very good in terms of precision and reproducibility. The best test of the two is the functional or enzymatic assay, because it will detect patients who have quantitative deficiency of antithrombin as well as who have the abnormal molecule. Unfortunately, it looks like enzymatic assays don't detect the variant in Jerry's family. And I would like Valentina's comments about what is the test missing? Do we need a different type of functional antithrombin assay to pick up Jerry's variant?
Yes, so what we are planning to do is doing a thrombin generation assay. So we want to purify his family's antithrombin and and purify not like a normal like a person who does like the antithrombin of a person who doesn't have the variant, and then perform thrombin generation assays with these different types of antithrombin to see if we can prove that you know, like the function of it is abnormal.
In terms of treatment, Anna, there's data, and I think we mentioned at least 2 references in our article where the direct oral anticoagulants were studied, rivaroxaban and apixaban. I don't think that edoxaban has been studied, but they were effective in all thrombophilias, including antithrombin deficiency.
Great. Thank you so much. And then do you want to just comment briefly on when you use antithrombin supplementation in addition to just anticoagulation? There's a couple different questions about which situations you use that in.
If I have a known patient with antithrombin deficiency, say they're an established patient, they're on an anticoagulant and they need surgery, we have to interrupt anticoagulation, I would replace them and then put them on prophylactic anticoagulation while they're getting replacement therapy. The other situation that I've used it before is in pregnancy. Even in a woman who is antithrombin deficient but has never been pregnant or ever had a clot, I would replace that patient's antithrombin during pregnancy and through 6 weeks of the postpartum period.
Great. Thank you so much. Okay, last question. This may be up high in the sky, but Dr. Restrepo, there's a question about whether there might be gene therapy available. Is that something that you've heard of or you know that folks are working on?
No, I have not heard anything about it yet.
And Dr. Rodgers, I didn't see it mentioned in your article, but it's an interesting question, and we're learning so much more about the genetic underpinnings of so many of our thrombotic and bleeding disorders that, you know, there's always hope for the future. So
I would think the potential is there, but I think about the expense of that therapy compared with just anticoagulation with a DOAC, just in terms of risk benefit, and I'm not sure how that plays out.
I think that's a great point. And then one other point that folks brought up in the Q&A is just the importance of lifestyle risk factors as well, which I think Dr. Restrepo kind of hit on, which is that, you know, there's a component that's definitely inherited and then absolutely a component that's mediated by lifestyle. And that's also on all of us as clinicians and patients to take into account as well as we're trying to reduce risk. Wonderful. Well, thank you all so much for joining us today. We're out of time, but thanks for everybody for attending today's webinar. Thanks for the insightful questions. And thank you all, Mr. Tracy, Dr. Rodgers, Dr. Restrepo, for attending and for providing these insights, Dr. Rodgers for writing this article, and Mr. Tracy for sharing so much about your family. Just a reminder that recording from today's webinar will be sent by email to all the registrants. And we want to thank Grifols for sponsoring today's event, and have a great rest of your afternoon. Take care.
Thank you.
Yeah,
Thank
thank
you.
you.